Alright guys, since we're running a bit over time, we should probably just get started. Wait for the thorax and back people to leave. All displays.
Well, just to be honest, just I don't know if it's going to work.
Alright, so I don't know if the other screen's going to come on. Technical difficulties, but the ECG should be on your laptops as well. This is more like of a lecture where you kind of understand the material rather than I deliver lots of content. And to be honest, you'll probably only have like 3-4 marks on the end of your exam on ECGs. However, I feel like ECGs are one of the more important skills you develop in your preclinical years, and once you hit clinical next year, you'll be expected to know how to read ECGs. It looks really bad if you don't know what's going on with ECG, and it looks really good if you do know. Alright. Okay. And just as a disclaimer, if anyone's above me, so like, or anyone my year level, so 3rd year, 4th year, 5th year, or a doctor says something and contradictory to what I say, believe them and don't believe me. Like, the only difference between me and you is that, like, I had 1 more year of experience, so anyone with more experience than me probably knows better than me. Okay, so ECGs, they could be an OSCE station. They probably won't in 2nd year, but you should still be prepared for it just in case. You probably will get questions on the exams for reading ECGs. They just want you to give a spot diagnosis, and I'll give you the list of ECGs you need to know. You will need it in clinical practice, and yeah. Okay. So the 2 resources to study are, well, I like Life in the Fast Lane and ECGs Made Easy. ECGs Made Easy is just a book you can borrow from the library. Life in the Fast Lane is a website. So if you ever come across like an ECG or a diagnosis, just literally Google, for example, like supraventricular tachycardia, Life in the Fast Lane, and it will come up. Okay? That's pretty much all I use to study ECGs. And this is a list of things you should know. So pretty much like arrhythmias and STEMIs are important as well. Okay. So we do an ECG whenever we suspect a patient might have cardiac disease or cardiac pathology. Essentially what it is, it just reads the depolarization of the heart. It's very quick and easy. You can do it in about 10 seconds and gives us a lot of important information. Okay, so we're going to make this interactive lecture and go around the room and answer some questions. So the guy in the front, I don't know his name. Come on. What symptoms would make you order an ECG? Yeah. So remember, heart disease doesn't just present with palpitations and angina. You also get things like syncope, breathlessness, and symptoms of stroke as well. So patients with focal neurological deficits, you would want to order an ECG in case they've had a stroke. Okay? So, person next to Josh, can you tell me what's wrong with this ECG? Just to see how much you guys know. Where? Where's? No, probably not. I think this is a normal ECG. Okay, we'll go over like STEMI criteria later, but there's probably like a little bit of artifacts affecting the baseline, but other than that, this is a pretty normal ECG, okay? So, just to go over the very, very basics, I'm assuming you guys have had your ECG stuff by Nadita. You understand what a lead is? Okay, so a lead just looks at the depolarization of the heart from a particular angle. So the 12-lead ECG has 12 leads. There's actually only 10 leads. We have 6 chest leads and 4 limb leads. They might ask you limb lead or chest lead placements as an exam question. I've put it there for you guys to remember. If I read it out, you're not going to remember it anyway. So just come back to it. Could be an exam question. The only difference is that V1, V2 are 4th intercostal space, whereas everything else, or V4 onwards, is 5th intercostal space. Okay? All right, so essentially, if you have a depolarization that goes towards your electrode, you're going to have an upstroke on your ECG. If it goes away, it will be a downstroke. Okay? Am I okay going quickly over this stuff? Yep. So if it goes towards your electrodes, upstroke. If it's perpendicular, you won't have any wave at all. Okay? So if you remember the chest lead placements, the leads essentially give you a three-dimensional image of what the heart looks like, okay? So we remember V1 was right parasternal, V6 is in your mid-axillary line. Okay, so V1 to V6 give you a good look at the anterior section of the heart, whereas leads, for example, 2, 3, AVF are good at the inferior aspect of the heart. Leads 1, AVL, V5, and V6 more the lateral aspect, okay? Does everyone understand the leads and how they look at the heart? Yep, we're good. Okay, so if you just have trouble understanding that, just think about it as a 2D section. So the precordial leads or the chest leads, looking at it in a transverse section, whereas leads 1, AVL, and 2 and 3, looking at it more in a sagittal section, okay? Sagittal? Coronal section. Okay. So it's important, not for exams, to remember the units of time and the voltage and all that for ECGs, but more for, is that a question? No. Okay, just so your understanding of like what's normal values or not. So 2 big squares up is 1 millivolts, and 1 big square across is 0.2 seconds. So therefore 1 small square is 0.04 seconds. Okay? That's just that in another diagram. All right. So if we remember the normal like depolarization of the heart, it starts at the SA node, spreads throughout the right atrium into the left atrium, passes through the AV node, which is, its function is to slow down the action potential to allow blood to go from the right atrium into the right ventricle. Then the depolarization spreads through the bundle of His, through the left and right bundle branches, and finally to the Purkinje fibers, okay? So the P wave corresponds to atrial depolarization, and the QRS complex corresponds more to your ventricular depolarization, okay? So this is what a normal ECG looks like. So you have your P wave, QRS, and T. So the Q wave is the first downward motion of the QRS complex, and the R wave is the first upwards slope, okay? Does anyone have any questions so far? Okay. So when you're reporting back in ECG, the preliminaries include, so you always have to double check it's the correct patient. So their name, the date and time of the ECG. You should always ask for previous ECGs to compare with if the patient is in any chest pain, because that can give you clues, and also their drug charts. So we know electrolyte abnormalities can affect the cardiac membrane potential, so therefore drugs that affect your electrolytes can affect your ECG as well. So specifically here, we're looking for drugs that may cause hyperkalemia. All right. So before you read your ECG, you should see like this calibration thing. Does anyone know why we always put this here, or why we always make sure this is calibrated correctly? So I said before that 1 big square across is 0.2 seconds, and 2 up is 1 millivolt. That's only if the ECG is calibrated like this. So if we've got a really, really fast heart rhythm and we want to slow it down, we can actually slow down how fast the ECG records, okay? And it will give us a better look of what the arrhythmia is. However, that means like your, for example, 3 to 5 small squares for a PI interval is not going to be the same, okay? So always just double check that your calibration is what you think it is. All right. This is evidence of artifact affecting your ECG. So there's lots of calibration errors. For example, if there's poor lead contact, if the patient's moving around, if they're shivering, if they've got like a really hairy chest, you know, it's all going to affect your lead placement. I don't really remember what all this is. I just describe it as artifact affecting the baseline. You can say it's a shifting baseline. As long as you mention it, you should be fine. Okay. So has everyone seen like these formulas before? Okay. Put your hand up if I'm going too fast at any point in time. I just want to skip over like the easier stuff before we move on. Okay. So the rate, okay, Tiff, do you want to tell me the rate of this first one? So, what is that? So, about 150, okay? I wouldn't be exactly like, oh, 300 divided by 2.1 is about like 153 or whatever. Just say 150, okay? So, for those who weren't following, it's 300 divided by the number of big squares between two R waves. So I would probably choose this one because it lands on the thick line. So it's really easy to see this is 1, this is 2. Okay, so 300 divided by 2 is about 150, okay? You could choose this one, choose this one. Yeah, choose ones that land on the bold line, okay? And Sean, for an irregular rhythm. Yeah. So, okay, so remember, the ECG graphs for about 10 seconds, yeah? So kind of a cheap way to do it is if you just count the number of R waves and then times it by 6, you'll have the number of R waves in a minute and therefore the heart rate in 1 minute, yeah? So this one, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, like 17-ish, yeah? So we can say 17 times 6 is 102. So this is a tachycardia. And Kelvin, what conditions cause an irregular heart rhythm? Yeah. So the way so if this was a faster heart rhythm, you could say this was atrial fibrillation with a rapid ventricular rate. Okay? So remember, if it's a regular rhythm, it's 300 or divided by the number of big squares between R waves. If it's an irregular rhythm, it's 6 times the number of R waves you see. Okay? Does everyone follow that? You can also, if you want to be more accurate, do 1,500 divided by the number of small squares. And that's because there's 5 small squares for 1 big square. So 300 times 5 is 1,500. Okay. So your rhythms can either be regular, regularly irregular, or irregularly irregular. Okay? So these are examples of a regular rhythm. So the time between all of the R waves is constant. This is regularly irregular. And this is irregularly irregular because we can't predict when the next R wave will be, okay? We have about like 6 big squares, then about 4, then 2, then 4 again, okay? Whereas this is, it's like a pattern, I guess. Okay? Cool. So this is just revisiting to the idea that atrial depolarization equals the P wave, and ventricular depolarization is the QRS complex, okay? Remember, ECGs are looking at electrical potential, they're not looking at the muscle contraction. So whenever you're talking about ECGs, you should always talk about electrical potential, talk about depolarization. Okay, we don't know for sure that this atria is contracting, okay? We know it's depolarizing. What's the definition of a cardiac arrest? Person next to Kelvin, tell me what the definition of a cardiac arrest is. So, close, it's no cardiac output, okay? So we can still have depolarization of our heart, but we don't have any cardiac output, okay? So we have things like ventricular fibrillation, when there's actual depolarization of the heart, but our muscles are fibrillating and not really ejecting properly, okay? So that's just an example of when depolarization might not equal contraction, okay? All right, so we'll slow down a bit now. So when we look at our P wave, you just see this tiny bump, right? But remember, you have 2 atria. You've got a right and a left atria. So our P wave actually comes about by superimposing the depolarization from the right and left atria, which you can see in this diagram down here. Okay? So the first part of the P wave is the right atrium. And remember, because the SA node begins the depolarization of the heart. And then the depolarization spreads into the left atrium. So that's responsible for the second part of your P wave here. So when we join these together, if we add this point up, this is our P wave. Okay? So conditions that affect for example, the height of the P wave, but not the width, are going to be conditions that affect the right atrium. Okay? Whereas conditions that prolong this P wave will be conditions that affect the left atrium. So if you look down here, you have a tall and rounded P wave or a tall and peaked. Okay? To be honest, they're not going to ask you the difference between rounded and peaked. You can see that this is a tall P wave, whereas this is a very wide P wave. You could describe this as biphasic or notched. And remember our diagram with the two triangles. With this diagram here, we've literally just moved the triangles further apart, resulting in this biphasic or notched appearance. Does that make sense? Okay. I'm not going to go over too much of the normal values just in this lecture because I think it's something you can read about and you're not going to remember if I just tell it to you. So just try and understand these concepts of why things occur, okay? So tall P waves, again, right atrial problems or right atrial hypertrophy. Wide P waves from left atrial hypertrophy, okay? So I think we're up to the person next to Kelvin. Oh, no, wait, finish you. So what conditions can cause atrial hypertrophy? Sorry, I don't know everyone's names, but... Yeah, so what's the umbrella term for what that's called? So valvulopathies, yeah? So not just mitral stenosis, but things like tricuspid stenosis, regurg, they'll all affect your atria. All right? And then I guess the next question is to ask what can cause valvulopathies. So, what's your name? Yep, good. Anything else? So think about common things, right? So heart failure, hypertension, they're more common than infective endocarditis. You've got things like rheumatic fever, COPD even, okay? And just old age can lead to calcification of your aortic valve and lead to valvulopathies, okay? So remember, ECGs are all part of the clinical picture. They're not an investigation on its own, yeah? So if you get funny-looking P waves, you can see in this diagram down here that the P waves look different preceding every QRS complex, okay? If you ever get an abnormal-looking complex on an ECG, it means it's not following the normal circuits. So this means that this P wave probably isn't originating from the SA node, okay? And because there's lots of different-looking P waves, there's lots of different parts of the atria that are causing atrial depolarization. So we can describe this as a multifocal atrial ectopic, okay? If it was just one weird-looking P wave, you could say that's an atrial ectopic. But because there's lots and lots of different ones, we'd say that's multifocal. Does that make sense? Okay. So the PR interval is essentially the time it takes. First of all, it's the start of the P wave to the start of the QRS complex. Okay? Remember that it's the start. So when you're counting it, it should be 3 to 5 small squares from the start here to here. Okay? So that's also 0.12 to 2 seconds. So the PR interval represents the spread of depolarization from the SA node to the ventricular muscle. So PR interval abnormalities will represent abnormalities when there's a block or a conduction defect from the spread between the atria and the ventricles, okay? So this is when you have your AV blocks. If your PR interval is too short, it suggests that the depolarization is not going through the AV node. Remember, the AV node's function is to slow down the depolarization, so it allows the right atria to contract, eject blood into the right ventricle, so it allows time for that filling, okay? So if it's too short, it suggests the depolarization is not going through the AV node, and it's going through an accessory pathway. So if it's too short, we call this condition Wolff-Parkinson-White, okay? You can see this PR interval is about 1, 2, 3. It's just within normal, okay? It's probably too short. And you can see this slurring upstroke before your QRS complex, okay? We call this a delta wave. So this patient has a decreased PR interval of about 0.12 seconds with a delta wave preceding the QRS complex. This is suggestive of a diagnosis of Wolff-Parkinson-White, okay? So instead of our depolarization going through the AV node here, it's going through this accessory pathway to the right atria. We call this the bundle of Kent. Any questions there? Okay. I can't remember who we're up to. Yep. Can you tell me what's wrong with this rhythm strip? So that's right. If you don't know, just say you don't know. There was like a study they did about people who learn the most in lectures. Yeah, and of course they found that people who participated learned the most, but it's the people that participate and get things wrong that learn the most from the lectures. So don't be afraid if you get things wrong. Means you're learning. But the PR interval, remember, is 3 to 5 small squares. Okay? You can see it begins at one thick line. So a normal one would have to come before this, yeah? So this PR interval is about 7 small squares, which is too long. So does anyone know what we describe this as? Yeah, first degree heart block. Okay, next. Petra? Yep, good. Anything else? Okay, what about, so you see a P wave, QRS, P, QRS, you see a P, and then no QRS. Okay? Again, does anyone know what this is called? Yeah, okay. So second degree type 1. Is this abnormal or normal? So this can actually be normal. If you've got athletes with increased vagal tone, you can actually have a second degree type 1 heart block, okay? So the characteristics are a prolonging PR interval. So it starts off a bit normal, then it's definitely too long. It's longer, really long, then you have a P wave and you miss a QRS complex, okay? Yep. Yep, so, did you say Mobitz 1? I feel like this is a Mobitz 2. Correct me if I'm wrong. Yeah, Mobitz 2. So I think type 1 is just Mobitz 1 and type 2 is Mobitz 2. So the difference between these two is that you still have a P wave that is not followed by QRS, but your PR interval does not prolong. Okay? Now the reason they make a distinction between type 1 and type 2 second degree heart block is because it has implications for clinical practice. And that is, you need to pace second degree type 2 heart block. Okay? So remember, this can be a normal rhythm. So patients that have this might not necessitate pacing, but patients with this will need pacing. Okay? And next person.
Is it missing a QRS complex?
What's this last one?
The
Yeah. So there's dissociation between your P wave and your QRS complex. Okay? So you can see a P wave, P, 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 and the QRS just comes in randomly, okay? So these two will need pacing, these two won't need pacing. That's why they make the distinction. Okay? So just as an aside, I think it's good to talk a little bit about the JVP. Next person. Can you tell me about the waves of the JVP? No? Okay. Can anyone tell me about the waves of the JVP? Mendel left 2 chocolates here, so like, if you want chocolate, now's the time. Okay. So I feel like JVP is really poorly taught. It's actually quite important, and it's really hard to elicit or see the JVP. First of all, can anyone tell me the difference between the JVP and the carotid pulse in terms of when you're looking for it or looking at it? What else? Yep. So, anything else? So the JVP also falls with inspiration. It is non-palpable, so if you see a double flicker in your cardio exam, go and feel it. If you can feel it, it's the carotid pulse. Okay, it should be biphasing and have a double flicker, because there's this A wave and this V wave. Okay, and if you occlude the JVP, you should see venous distension in the neck above where you occlude. Okay, that doesn't happen with the carotid pulse. Okay, remember venous filling goes down, so if you occlude it, you're stopping venous return, whereas the carotid pulse is coming up. Yeah? So this A wave, so remember the JVP corresponds to right atrial pressures, yeah? So the highest pressure occurs when the right atria contracts. It contracts to eject blood from the atria into the ventricles. Okay? Then, as the blood empties from the atria, it goes down. And then it comes up as blood from the vena cava, empty blood into the atria again. What is this C wave? Yeah, so it's the tricuspid valve pushing back into the right atrium, yeah? So that's responsible for this tiny C wave. It's not the flicker you see with the JVP, it's actually quite small, okay? So therefore, should this be your S1 or your S2 heart sound? S1 heart sound, yeah? So systole occurs from the start of C, okay? After the V wave, or when you have your Y descent, that's when blood empties from your atria into the ventricles, yeah? So systole is between your C and your V. A is atrial contraction. Does that make sense so far? Everyone understand that? Okay, so it's possible for them to ask you about the abnormalities of the JVP. So if you just remember this diagram and you think about it, it kind of makes more sense. Okay, so remember, this part is when blood is emptying from the atria into the ventricles. Okay, this is when there's filling of the atria. Okay, so does anyone know who we're up to? Yep. What can cause large V waves of your JVP? So if you think about it's blood has to come back into the right atrium, right? And there's not really a physiological reason why we're just suddenly going to have a large increase of venous return during systole, yeah? That doesn't make sense. So where's the blood coming from then? Yeah, from the ventricle. So if we have a condition like tricuspid regurg, where the blood is ejecting from the ventricle back into the atria, this is going to cause a very large V wave. Yeah? It's going to have increase of volume inside the atria, increase in the pressure. Does that make sense? Large V waves are from tricuspid regurg because there's a regurgitation of blood from the ventricle into the right atria, increasing right atrial pressures. Okay, what about Cannon A waves? Who's next? Okay, so what is the A wave again? Yeah, so atrial systole. So if the atria is contracting against the closed tricuspid valve, the pressure is going to skyrocket, right? It's contracting and the blood's not going anywhere. Yeah? So what conditions before did we learn about that can cause an atria contracting against a closed tricuspid valve? So remember, complete heart block. So you've got all these P waves suggesting the atria contracting, but the tricuspid valve is closed, right? So therefore we have Cannon A waves. Yeah. Does that make sense?
What does a Cannon A wave do?
So they use all these fancy words. It just means like you'll see really big A waves. So remember you've got a double flicker, right? So if you see a really large second flicker, it suggests a large V wave. If you see a very large A wave, it suggests a Cannon A wave. It's supposed to be really, really big. That's why they say it's a Cannon A wave. I can't tell you the difference between Cannon and large. A cardiologist will probably be able to tell you, but it's just the terminology they use. Okay? Yeah, so remember, the JVP physically goes up and then up. Yeah? Okay, what about absent A waves? Yeah, so what condition is it when your atria is not contracting properly? We talked about it before as well. Yeah, atrial fibrillation. Yeah? So atrial fibrillation, your atria is not contracting properly, you won't see a proper A wave. Okay? Can you see how everything in cardiology kind of ties together? you can tie together your JVP, your ECG, as well as your clinical findings, right? If a patient comes in with a stroke, they've got right arm weakness and loss of sensation, you look at their ECG, there's an irregular rhythm, and on examination, they've got loss of A wave of their JVP. Yeah, everything comes in together. All right, so this is something you definitely don't need to know, but it's good just to test your understanding. I'll give you a chocolate if you can tell me why you might see a very sharp Y descent. Who said that? How'd you know that? You should have told me like you just knew or something. Yeah, have a chocolate anyway. Thanks. Okay, so let's talk about why you have very sharp Y wave, yeah? So this Y descent, remember, is blood after ventricular systole. The tricuspid valve is now open, and now we have blood that's going from the right atria into the right ventricles, yeah? So we have diastole here. Okay, so the way we increase blood going into the right ventricle is by having less pressure in the right ventricle. Kind of like when you breathe, your lungs expand and that draws air in. If the right ventricle somehow gets bigger, we're going to draw blood in. Okay? So that's responsible for a very sharp Y descent. So let's talk a little bit about why that happens. So when you've got very large pericardial effusions, as can occur with pericarditis, you can have constricted pericarditis. You want to physically imagine your heart inside a fluid-filled sac. Okay? Except this fluid-filled sac is physically compressing on the heart, and it's stopping it from stretching. Okay? So if it's stopping it from stretching, your left atrial and your left ventricular pressures will be higher. There's going to be less return from the pulmonary veins into the left atria because of that pressure difference. Does everyone follow that so far? Okay? Remember, the heart has a great propensity to stretch. If it can't stretch, it can't fill. Okay? So less filling of the left ventricle means that in proportion to normal, there's negative pressure in the left ventricle. Okay? It's not really negative, but when we compare it to what's normal, there's negative pressure. Okay? So this actually shifts the interventricular septum from the right side to the left side. Okay? So by shifting that septum, we've increased the volume inside our right ventricles. And because volume and pressure are inversely proportional, we're sucking blood into the right ventricle. Okay? That's responsible for the very, very sharp Y descents. Okay? So this is another diagram of what I've just explained. The Y descent is very quick because the right ventricle's volume is bigger. Okay? Now it comes up again very quickly because, again, we have so much fluid around the heart that it can't stretch, and it fills very quickly. Okay? So if you didn't understand that, that's okay. You won't be examined on that probably ever. But I think it's good to test your understanding if you could follow that. Okay. So again, following on our clinical picture, what ECG findings will you see with a large pericardial effusion or pericarditis? Yep. Just have a go. If you're not sure, then say you're not sure. Okay, that's okay. So you actually see this diffuse ST elevation. Okay, this is a differential if you get ST elevation in your OSCE, for example. It's in all leads apart from AVR and V1, where you have reciprocal ST depression. And in all the other leads as well, you have PR depression, okay? So this is your isoelectric line, and you can see the PR interval is depressed, whereas you have ST elevation. They typically describe this as saddle-shaped. It's meant to look like a horse's saddle. Yeah, and it's good to know. You'll definitely need to know this next year. Okay? Now, can anyone tell me, or the person next, can you tell me, don't tell me like, exactly what's wrong, but like, why is this ECG different to a normal ECG? Good. So it's not really taller than the other one, it's just alternating. Okay? So can you think of why this might be? Okay. So remember, if we've got a large pericardial effusion, First of all, you can see the QRS complexes are also of quite small amplitude, right? Everyone can see that. And that's because there's physically more distance between your electrode and the heart. The QRS amplitude will be smaller. Now, the reason why it's alternating is because if there's so much effusion, your heart can literally swing back and forth, resulting in this pattern we call electrical alternans. Okay? It's because the heart's swinging back and forth. Does that make sense? Cool. All right, how's everyone doing so far? Cool. So the QRS complex represents ventricular depolarization. Just again, as another aside, if you see deep Q waves like you do here, that can suggest a previous myocardial infarction. Okay? So a big Q wave, remember Q wave is the first downstroke of your ECG, or of your QRS complex, sorry. Deep is bigger than 1/3 of your R wave. Okay, so this R wave is about 5 small squares. This is about 2.5. So it's about half the size of the R wave. So therefore we can say this is a deep Q wave suggestive of a previous MI. Okay? Any questions? All right. Who are we up to? Can you tell me what's wrong with this? Good. So which one's the ectopic? Are these both ectopics? Is this one the ectopic, or are they all ectopics? Okay. What does your gut tell you? Sorry? Okay. So they're all ectopics. Yeah. They look different from your normal QRS complexes. They're very wide. They just look weird. Okay. There's probably a classification criteria for what an ectopic is, but they just look weird. Yeah. So, yeah, weird. So abnormalities of a QRS complex, you can either be too wide, too big, or too small. Right? So we talked about being too small before, if you've got edema. Or also, like, if you've got a patient with high body habitus, they're going to have small QRS complexes as well. So take it with a grain of salt. All right? Wide QRS complexes we see in conditions like bundle branch blocks, ectopic beats, as well as ventricular tachycardia. Okay? So have you guys heard of the term supraventricular tachycardia before? What does that mean? It means the tachycardia is originating from above the ventricles. So ventricular tachycardia means the tachycardia is originating below the ventricles, or in the level of the ventricles. So therefore, it's not going through the normal conduction pathways, resulting in a very wide QRS complex. Okay? I'll show you a diagram of that later. Yeah, kind of. So supraventricular tachycardia just means above the ventricles, but there's lots of different places inside the atria that can cause a tachycardia. So I haven't really heard the term atrial tachycardia used. You either describe a tachycardia as sinus tachycardia, which is if it's originating from the SA node. You can have multifocal atrial tachycardia, which I showed you before with lots of funny different looking P waves. And you can also have AV nodal re-entry tachycardia, where the AV node is responsible for the tachycardia. Okay? It's not something you need to know, but so supraventricular tachycardia is just an umbrella term for all those conditions. Okay? So increased amplitude occurs if you've got more ventricular muscle, there's more electrical potential, and therefore you have bigger QRS complexes. All right. Yep. Sorry, I don't know your name. Okay, why do you say it's a left bundle branch block? Yeah, okay, so good. Does everyone see how this is an M? And you can pretend this is a W. We'll talk about why it's not in a second, but can everyone see that? Has everyone heard of William Marrow? Okay, William Marrow is a mnemonic, not really a mnemonic, but just a study technique or tool you can use to help you remember left and right bundle branch blocks. Okay, so when we pass through our bundle of his, we've got a left and right bundle branches to depolarize our left and right ventricles. Okay? And you can have conduction defects in either your left or right bundle. So if you have a left bundle branch block, you remember William. Okay? So in lead V1 or V2, you'll see a W pattern. Okay? And if you have right bundle branch block, so the two R's, you have an M pattern in V1 and a W pattern in V6. Okay? Does everyone understand how to use William Marrow? I think it's important to note that the W pattern should be below the isoelectric line. Okay? If you see a W pattern that's up here, that's not left bundle branch block. Okay? Even though it might look like a W, it has to be below the isoelectric line. So this M has to be above the isoelectric line. Okay? So we can see from this diagram that the William Marrow thing isn't always 100% true. This doesn't look like a W. Yeah, maybe. Okay? Other clues you can use to guide you is that the QRS complex is actually quite wide. Okay? So the numbers is like less than 3 small squares is the normal QRS width. This is about 1 big square. Okay? There's also evidence of left axis deviation, which is another thing you see with left bundle branch blocks. But if I was saying this, I wouldn't say there's a W pattern in V1. I'd say there's a dominant S wave in leads V1 with an increased QRS width. Okay? And then there's an M pattern. Okay? Does that make sense? So wide QRS complexes increase your clinical suspicion of a bundle branch block. Okay? Not just a W or an M. Okay? Yeah, so this is just reinforces what I was saying. This is too wide. Okay? This is below the isoelectric line, above the isoelectric line. Pretend this is a W, pretend this is an M. We have William, or left bundle branch block. Okay? Does that make sense? So these are other things you can see in a left bundle branch block. Don't remember them. The important one is QRS duration of greater than 120 milliseconds, which is 3 small squares. Okay? Don't remember about how the Q wave moves and how the R wave moves. Don't waste your time, okay? So what do we call it when we have first degree heart block and, for example, a left bundle branch block? Anyone? So we can describe it as a bifascicular block, okay? If we have axis deviation as well, we can describe it as a trifascicular block. It's important because the more blocks a patient has, the higher chance they have of going into complete heart block. If they go into complete heart block, they could die. Okay? Next person. Tell me what's wrong with this ECG. Yep, so there's an ectopic here. Okay? Anything else? Do you think there's some evidence of ST depression? Yeah? There probably is. Okay? Is there anything else here? Probably not. Alright. So this is the isoelectric line for lead V2, yeah? Can you see that the ST segment is depressed? Who knows? This is why you get previous ECGs to compare with. The cardiologist probably knows. I don't know. You can get ST depression when you have myocardial ischemia as well. But in isolation in one lead, who knows? Like it could be just be normal for that patient. Yeah. Yeah. All right. Next. All the people sitting at the back being like, yes, thank God I sat at the back, right? Okay, what do you think looks abnormal? what do you think about the shape of this QRS complex and the shape of this QRS complex? Okay, so this is the M shape. This is a W shape for right bundle branch block, yeah? Okay? We'll go over like reading complete ECGs a bit later. I just want to get you to recognize the patterns. In the EMQs you get, the patterns will be what they're testing you on. I forgot to mention this earlier, but you guys know that like this QRS complexes should be the same beats or the same depolarization, right? So this should be all the same. This should be all the same depolarization, all the same depolarization, all the same, yeah? I also forgot to mention this earlier, but if you're looking for P-wave abnormalities, where should you look? What lead is closest to the right atria? V1, yeah? So if I want to look for right atrial abnormalities, I should be looking at lead V1 because it has the closest contact or the closest distance between the right atria and therefore best reflects whatever's going on in the right atria. All right, so ventricular hypertrophy is when you get big ventricles, can occur when the ventricle has to pump out against high pressure, hypertension, heart failure, valvulopathies, okay? Now, there's like a classification criteria you need to know, and the magic numbers you need to know are 7 and 5, okay? So, which ventricle is bigger, the left or the right? Left. So therefore, the classification criteria for the left ventricle will be 7 big squares, whereas the right ventricle will be 5 big squares, okay? So remember, left is 7 because the left ventricle is bigger. Right is 5 because the right ventricle is smaller, okay? So what we actually do is, you can see these QRS complexes of quite big amplitude. So we either choose, in this one, would be choosing the biggest S wave in V1 and V2, and adding it to the biggest R wave in V5 and V6, okay? So remember, V1 is here, V6 is here, right? So if we've got a big upstroke around V1, it means we've got big right ventricles. If we have a big upstroke over this side, over V6, it means we've got big left ventricles. So because of the upstroke around V6, we're looking for clues suggesting right or left ventricular hypertrophy. Okay? So if we add up the biggest S wave, so in V2, what's that? 1, 2, 3, 4, 5, 6, 7, 8, 9, plus 10, 11, 12, 13, 14. Okay? That's bigger than the number we needed, which was 7. Okay? So this is left ventricular hypertrophy. Does that make sense? Yep.
Right ventricle is 5 big squares?
5 big squares.
But it was 10 small squares. Which is
Same. Wait, 10 small? No, not 10. No, not 10. Is it 10 small squares?
yeah.
Oh, okay, well then, maybe it's 10 small squares. Remember my first slide? I was like, don't trust me. Yeah. Okay, if you guys have learned 10 small squares, go with 10 small squares. Okay? But my point about V1 and V6 having the upstrokes, yep. Remember, that's how you remember which one's which, yeah? Don't remember, V1, big R wave, you know, McDonald's. Someone told me, like, for bundle branch blocks, if you put an M here, McDonald's is on your right-hand side or something like that. So therefore, right bundle branch is M or something like that. Like, yeah, just remember things how they should be. I think med students always come up with like super ways and like mnemonics to remember everything, and sometimes it's just best to like remember why it is instead of like just a list of things. Okay, that's just what I've said in words. All right, so moving on to the ST segments. We look at the ST segment as from where the J point is, and the J point or the junction point is the junction between the QRS complex and this ST segment. So we'd say it's this point. Okay? So this is our J points. This is our J points. Okay. The isoelectric line is the PI interval before it. So we're looking at this ST segment in relation to the PR segment before it. So everyone's heard of STEMIs and NSTEMIs. Okay. So what's angina? Next person.
Like pain in the card, but
Okay, so you guys have all learned about NSTEMIs and STEMIs, yeah? So let's say a patient presents with chest pain. What's the difference between angina and unstable angina, or NSTEMIs and STEMIs? You can't just say, oh, they've got chest pain, right? You have to, what increases your suspicion of one versus the other? Just in history. Okay, so remember, angina is reproducible. Yeah? So you might walk for 50 meters and then you get that chest pain, and it's always 50 meters. It goes away with rest, and it goes away with glycerol trinitrate. Okay? These other three we group together because we can't differentiate them in history. Patients might present with chest pain on rest, changing stable angina. So previously they could walk 50 meters, now they can only walk 10 meters. Okay? So it's changing. The severity of the chest pain isn't really a very specific factor. Because someone has 10 out of 10 chest pain compared to 8 out of 10 chest pain, it's not going to increase your suspicion of a STEMI versus an NSTEMI. The differentiation here comes from your ECG as well as your bloods. Okay? Has everyone heard of troponin? Yes. So it's an enzyme that's released in cardiac myocytes damage. Okay? It's elevated in a STEMI and an NSTEMI, not in unstable angina. Okay? So we've ruled this out. The way we differentiate between a STEMI and an NSTEMI is, as the name suggests, ECGs. In this one, we'll have ST elevation. In NSTEMIs, we don't have ST elevation. Okay? Does that make sense? So NSTEMIs are subendocardial infarctions, whereas STEMIs are transmural. Okay? Transmural means it affects the full thickness of the wall, whereas this is only the subendocardial layer. Troponin, I said, was released in myocyte damage, so it's not very specific to myocardial infarctions. In arrhythmias, in things like myocarditis or pericarditis, PEs, pneumothoraces, cardiac tamponade, we'll all have a rise in troponin as well. Okay? So the way we define a STEMI is if we have ST elevation in two contiguous leads. What does two contiguous leads mean? So remember the first diagram of where the leads were looking at the heart, right? Just because the leads are next to each other on the ECG doesn't mean they look at the same section of the heart. So we group the leads in terms of anatomical location, which is what contiguous refers to. So if we have ST elevation in, for example, leads 2, 3, and AVF, that would suggest an inferior STEMI. Okay? So the numbers we need are 0.1 millivolts in limb leads and 0.2 millivolts in the chest leads. So 2 millivolts is 2 small squares. Okay, 1 millivolt is 1 small square. Does that make sense? Okay. Next person. Can you tell me which one of these is a STEMI? Middle top? Okay. Next person. Which one do you think? Not this one? Okay. So this is a trick question. These are all STEMIs. Okay? Just because you have ST elevation, always, if you have ST elevation and you don't know what's going on, just say STEMI, yeah? The point I'm trying to make here is that they can look very weird and look abnormal. If you see ST elevation, STEMI should be one of the top differentials you have, okay? There's not really a classical picture that ST elevation has. People often describe this as tombstone ST elevation. I don't know if it's got like a correlation to patients dying from really bad STEMIs. So this is maybe a classical one you could remember, but ST elevation can be very, very different. Okay? So next person, which one of these is a STEMI? Now, it's another trick question. So none of these are STEMIs. Okay? So the point is, if you can't tell which one is a STEMI and which one isn't, just say STEMI, okay? And it's also hard, because I'm giving you one QRS complex. Remember, ECGs are all part of your clinical investigations. After you've taken a history, after you've done an exam, you're doing bloods, you're doing a troponin, okay? That altogether will increase the likelihood of a STEMI. Okay, it's not just, okay, I see ST elevation, you're going to have a STEMI, okay? But that's not what's going to be your OSCE is. So this first one is the saddle-shaped ST elevation I talked about before with pericarditis. Remember, you might get the electrical alternance. If the effusion is large enough, you might get small QRS complexes, and you'll see a sharp Y descent in your JVP. This second one is benign early repolarization. For some reason, these people just have ST elevation. Okay, it's benign, means it's not bad, nothing's going to happen, they'll live. This one is left bundle branch block. Okay, remember that W pattern and a widened QRS complex. So I suppose the next question people have is, how do you tell the difference between a STEMI in a patient who normally has left bundle branch block then? And the answer is, there's other criteria. So for people who are interested, if you look up Scarbosa's criteria, it's a criteria for left bundle branch block and ST elevation. Okay. I guess easier question. What symptoms would increase your clinical suspicion of a STEMI? Okay, so be specific. So remember, you guys taught your histories of WWQQ, ICEs, right? So tell me, like, in that type of format.
Sharp stabbing pain. That's like very painful.
Very painful. Okay. Is angina pain usually stabbing? Yeah, so patients often say it's tight, it's squeezing, it feels like an elephant sitting on their chest. Okay? So whenever you report back now, just get in the habit of going through that WWQQ, ICEs kind of structure. So a patient might experience central crushing chest pain that radiates to the jaw and down the left arm on a background of nausea, vomiting, and dyspnea. Okay? They might have a past medical history of diabetes, hypertension, and they're a smoker, and might also have a family history of heart disease as well. Okay? So if you say that in your OSCE compared to he's just got central stabbing chest pain, I reckon it's a STEMI. Okay? There's a big difference. And the point here, again, I'm trying to make is that ECGs are all part of things you're doing in a clinical practice, right? It's not something you do in isolation. Okay. So the T wave represents ventricular repolarization. It should normally be in the same direction as your QRS complex. And these are the sizes you need to know. So less than 1 large square in limb leads, less than 2 large squares in chest leads. This is a T wave. Yeah. Okay. So peaked T waves you can see in times of ischemia. And you can also see peaked T waves when you have hyperkalemia. So you're up the top there. Okay. Yep. Can you tell me, how would you tell the difference between T wave being peaking due to ischemia versus hyperkalemia? All the answers there. Okay, so, yeah. What's the difference between hyperkalemia and ischemia in terms of your T wave? Don't know? Does anyone know? Not really symmetry. Okay, so will electrolyte abnormalities affect one part of the heart or all parts of the heart? All parts, right? Will ischemia affect one part of the heart or all parts of the heart? So usually one part of the heart. So therefore, if you have peaked T waves in one part of the heart, it's more likely to be ischemia. Whereas if you see peaked T waves like you do here in every single lead, it's more likely to be something like hyperkalemia. Okay? Next person. Can you tell me what's wrong with this ECG? I don't think there's delta waves. There's some funny looking P waves here. But if you look in lead V1, the P waves they're alright, they're not too bad. Yeah, I think this one's a normal ECG.
Within V4, V5, is that a P by trial?
Is it what, sorry?
Is there a P by trial in V4, V5? There's like a by phase?
Oh, a little bit. You can see a little bit here as well, in like V3. So, P mitrale is the same thing as left atrial hypertrophy. in mitral stenosis, your left atria has to contract against a high pressure. Left atrial hypertrophy results in that bifid P wave. It could be. Yeah, it could be. All right. Cool. So this is another thing that could increase your clinical suspicion of a STEMI. This is called Wellens syndrome. If you have a biphasic T wave, so it goes up and then down in the anterior lead, so V2, V3, V4, that suggests an imminent LAD occlusion. So this is the type 1 Wellens. Type 2 Wellens is when you've got a deeply inverted T wave. Okay? Okay, and the next one is De Winter's T waves, when you have ST depression and then a very high peaked T. Okay? And they're both suggestive of imminent LAD occlusion. You won't be examined on a Wellens syndrome and a De Winter's T waves, but most of the things I talk about in this lecture you need to know for next year, so just know it now anyway. This is an example of De Winter's T waves. You see this ST depression with his peaked T's, only in the anterior leads, yeah? You don't see it anywhere else. Okay, so again, this is a list of things you should know for your exam. You'll notice that De Winter's T waves, Wellens syndrome aren't here. Okay, constrictive pericarditis is not here. These are the things you need to know. So these are the things. Okay, just learn it for your exams. Okay. So in terms of steps of reading your ECG, just go in order of what your QRS complex or your PQRS is. Yeah. So you start with your rate, rhythm, axis, then your P wave, PR, QRS, ST, T. Okay? Does that make sense? So before we move on, I'll talk a little bit about the cardiac axis. Is anyone confused about this? Do you guys know how to calculate the axis of the heart? So the axis is the overall direction that the heart points. So remember the heart kind of sits like this here and it points down here. So the normal axis of the heart is somewhere down here. Okay? So if we have left axis deviation, that means the depolarization is going this way, yeah, in our chest. Right axis deviation is if the depolarization is going this way, and northwest, or like no man's land, is if the depolarization is going up. Okay? So you can imagine why that would be bad. Like, yeah, your heart's not doing its job properly. Okay? So the leads I look at for axis deviation are leads 2, 3, lead 1, lead AVF, and lead 2. Okay? So left axis deviation is this quadrant here. And you can see lead 2 is perpendicular to AVL. Okay, or it's perpendicular to where the normal axis is. Okay? So that means if lead 2 is positive, we're in this region. If lead 1 is positive, we're in this region, or this region. If lead AVF is positive, we're down here, or down here. So when I'm looking at the axis of the heart, I first look at lead 1 and lead AVF. If they're both positive, so if 1's positive, so we're over the right side, and if AVF is positive, we're down in the right lower quadrant, we have a normal axis. Does that make sense? Right axis deviation, lead AVF is positive, so we're down here, and lead 1 is negative, so on the left side. So down and left is right axis deviation. Okay? Now the reason lead 2 is important is because if lead 1 is positive and lead AVF is negative, it just means we're somewhere up here. Okay? It doesn't tell us whether we're normal or whether we have left axis deviation, which is why we look at lead 2. So remember, lead 1 is positive, AVF is negative, so we're up here. If lead 2 is then positive, we're here. If lead 2 is negative, we're over here. Does that make sense? Is anyone confused about that? Does everyone know what I mean by positive and negative? So if your QRS complex points up, it's positive. If it points down, it's negative. Okay, that's that in words. But just remember it. Remember why, yeah? So who are we up to? I can't remember. I think, is it you or? Have you answered the question yet?
Yeah.
Okay. So the girl with the glasses, yep. Can you tell me what the axis of this ECG is? Yep. Yep. F. Yep. 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 Does everyone understand that? Left axis deviation. Okay, so if lead 1 and AVF, so lead 1 is positive, AVF is negative, so we're up here, yeah? This area. And then we look at lead 2. So does everyone know how to work out axis now? Yes? Put your hand up if you're confused. Okay, hopefully we're good. All right. Okay, so we've got this guy is a 65-year-old diabetic with a past history of type 2 diabetes, dyslipidemia. He presents with sudden onset chest or dyspnea and diaphoresis that began half an hour ago. He has no chest pain. However, you do an ECG. Please interpret. Next person. So for your OSCEs, of course, do your rate rhythm axis. We don't have that much time left. So just if you can see a diagnosis, tell me. Where? Yep, and 3. What does that suggest? Where? Anterior. Yep. So, and then following on from that, an anterior STEMI is an occlusion of which artery? The left anterior descending? Yep. So, yeah. Okay, so next person, tell me why he doesn't have chest pain. Yeah, diabetic, go free pass, diabetic autonomic neuropathy. So he doesn't have chest pain, okay? So when you're describing the ECG, don't just say he's got ST elevation, right? So he's got ST elevation in the anterior leads, which suggests occlusion of his left anterior descending artery, okay? So this is Mr. Vu's wife, who also presents with diaphoresis, dyspnea, nausea, and vomiting, okay? Yep. Can you tell me about her ECG? Yep, it's above. It's above. Remember, in the limb leads, we need to be one small square above, yeah? So even though it's hard to tell, the J point's probably here. There's probably about 2 or 3 small squares. So that's definitely ST elevation. Yeah? Yeah. Which is what artery? Yep, which is a branch of... Good. Okay, and there's also ST elevation in lead 3 as well. Okay. Any other changes anyone can see? Yep, so they're bradycardic, good. And there's also some reciprocal ST depression as well. Okay, so remember how I showed you guys the saddle-shaped ST segments? Do you reckon these look a little bit saddle-shaped? They do, yeah? But this is still a STEMI. Now, in pericarditis, you don't see any reciprocal ST depression because there's no actual ischemia of the heart. So if you see ST depression, reciprocal ST depression, in the presence of ST elevation, that's more suggestive of a STEMI rather than pericarditis. Okay? So, yeah, she is bradycardic. So can the next person tell me why she's bradycardic? Okay, so that's okay. Have you guys remembered about dominance? And like right dominant versus left dominance? What does that refer to? Yeah. So I'm hearing which coronary artery supplies the SA node, yeah? So if you have, most people are right dominant. So if you have compromise to your right coronary artery, you're going to have decreased blood flow to your SA node, resulting in that bradycardia, okay?